on this webinar. As usually, this is a CPD accredited webinar, and we also have these webinars recorded on YouTube. So after the presentations, you are quite invited to access our YouTube page and like us in YouTube, and then you'll be invited to future webinars. Or you can access even previous presentations by different speakers. And also know that we request that when you log in, please also mute yourself and switch off your video so that we enhance the quality of the feed that we're getting from Zoom, and that we are able to continue the presentations unhindered. So this evening, we are quite excited to have one of the specialists in HIV and TB medicine, Dr. Tom Boyles, who is qualified at Oxford University Medicine in 2000 and moved to South Africa in 2007. I was just talking to him that when he moved to Joburg, he moved to a hospital where I used to be the CEO, and we just missed each other. So we never met at that time. But he spent most of his time in the Eastern Cape as an HIV physician at a rural hospital in the Eastern Cape. He trained as an infectious disease specialist in Cape Town from 2010 to 2012 and continued to work at Hospital Hospital until 2017 when he moved to Joburg. And he currently works for Right to Care, the Clinical HIV Research Unit, and as a consultant at Joseph Hospital. He maintains a passion for rural medicine, and his research interests include appropriate diagnostic and treatment strategies for TB and the increased use of machine learning. We've done that sometime last year. It's exciting to know that there's someone who does this also. And he uses this to advance healthcare delivery in low resource settings. And so we invited Dr. Tom Boyles to speak to us on the advances in the treatments and diagnosis of tuberculosis. And so we're excited to have you, Mr. Dr. Boyles. It's a weekly webinar and quite an exciting platform to share information and interact with colleagues from different backgrounds and in the medical fraternity and nursing and allied health disciplines. So please talk to us. Thank you very much and welcome.
Thank you, Dr. Bila. Appreciate it. Thanks very much. I hope everyone can hear me and see my screen. So
yeah,
they can hear me and see my screen. Okay, good. Excellent. So yeah, the topic I was asked to speak on was the advancements in TB diagnosis and treatment. And so I'm going to sort of assume a background knowledge of where we were up to a couple of years ago. And most of the advancements have been in treatment, but I'm also going to cover a little bit of diagnostics. And it just reminded me, Dr. Bila just reminded me that I could quite easily have put in a few slides on machine learning, and perhaps, although I haven't got the slides, perhaps towards the end, we might just discuss a little bit about machine learning, which has been quite important in some areas of TB diagnosis. I'm just trying to advance my slides. Okay. Yeah, I've got it. So I'm actually I want to keep this a little bit more interesting than just going through all the papers that there are on new controlled trials of treatment, although I am going to do that. But I'd like to put this at the beginning of the talk to give everyone a sort of flavor of the way people are thinking about TB in the last few years. This is a paper authored by Hanif Esmail, who's a good friend of mine, about tuberculosis being a disease spectrum. Now, this is taken directly from the paper, and I've blanked out the middle, which I'm going to show you. But for a century or so, we have generally considered TB to be on either the left-hand side or the right-hand side of this diagram. So we've said once you get TB, you maybe get this go and focus, which is up here in the lung, but you are asymptomatic and you're what we call immune sensitized. And if we did any tests on you, sputum tests, they'd all be negative. And if we did your chest X-ray, it would be essentially normal. It might have a tiny little dot in it, but basically it would be normal. And if we did some, this has often been called a latent TB infection. If we did some latent TB screening, that is, we did a tuberculin skin test or a quantiferon interferon gamma release assay or something, it would be positive. And then we would treat you with, and we will come to this later, some regimen. It used to be something like 6 months of isoniazid, but there are also other regimens, 9 or 12 months of isoniazid, 4 months of rifampicin, 3 months of isoniazid rifampicin, 3 months of isoniazid rifapentine given weekly, or 1 month of isoniazid rifapentine, that's the P. These various regimens that we would give. And future approaches could be things like therapeutic vaccines, which is when you give someone a vaccine who's in this state, they've got TB, and it prevents them going from TB to on the right-hand side. So what we typically think on the right-hand side is the symptomatic disease, where somebody's got an abnormal chest X-ray, perhaps a cavity. All of their tests are likely positive. Their smear, culture, and gene expert are positive. And the very, maybe extensive abnormalities, and we treat that person with, so I'm just moving this because it's, we treat this patient with, typically 2 months of 4 drugs and 4 months of 2 drugs, standard treatment therapy. But actually, that we now know that it's far more complex than that. And actually, you don't flick a switch and move from the left-hand side to the right-hand side overnight. It actually takes a significant amount of time to move from the left to the right. And you can also move in both directions without even having treatment. You can, and I'll show you something about this now, you can move from left towards the right, and then you can move from the right towards the left without even having any treatment for TB. And I'll show you some data for that now. And so, this is just one of the diagrams showing how we're starting to think about TB now. And so, once you've got this so-called latent infection, you might move towards what we might call subclinical disease, that being the asymptomatic TB, but it's more than you have on the left. You've got some abnormalities appearing on chest X-ray, and you've got you're starting to get possibly some positive tests. You might get a positive culture, but you've still got no symptoms. And then you might move into starting to get symptoms, but we know there are people with symptoms who still have all their tests are negative. And then people can become more symptomatic, and maybe they've got their smears are negative, but their cultures are positive, clinically positive disease, and then you end up on the far right-hand side. And as things move along, your chest X-ray gets worse. The way we find we find asymptomatic patients with active case finding, because they don't come to the clinic on their own because they're asymptomatic. We have to go and find them. And you find symptomatic disease typically with passive case finding because they come to you because they're sick. But what's interesting really is that we still only have 2 modes of treatment. We only have the left-hand side here, the so-called TPT type of regimens. And then we have the 6-month regimen, which is here, 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 and probably here. We don't have anything in between, and that we're starting to realize that doesn't really make sense. And actually, it's almost certain that we know that this treatment on this side is sort of 95% effective, but we're pretty sure that much shorter regimens will be effective here. So I just want you to keep that model in your mind of what TB is. And some of the studies at the bottom here, these new approaches I'm going to explain to you, because there are some studies in some of these groups already now, particularly the SHINE study, which I'm going to show you, of children, and the study 31 in adults, and a few others. But just to say, as a follow-on from that paper, the same group as Hanif Esmail and others, including Banka Sossen, they both got positions at the University of Cape Town, did a very interesting study. This is only published, it's not peer-reviewed, it's on medRxiv at the moment, but it will be peer-reviewed, published soon. And they wanted to understand the natural history of untreated pulmonary tuberculosis in adults. Just to be clear, this is all in adults. So they wanted to, and so what they realized is that for quite a long time, a lot of the 20th century, there were no treatments for TB of note. And so, but there were tests. So there were chest x-rays, and there was culture, and there was sputum smear, but no treatment. And so there are actually some studies from the middle of the 20th century where we can actually look into this and see what was happening. People were actually picked up at this asymptomatic chest x-ray stage when nothing happened to them. And even people who were symptomatic and sick, they didn't get any treatment because there wasn't any treatment, but people still followed them and studied them. And so what they found was that progression from microbiologically negative but a positive chest x-ray to the far right-hand side occurs in about 10% of people per year. But there's also a reversion in the opposite direction. People go from, people essentially cure themselves without treatment at about 12% a year. So, and this arrow doesn't go all the way to latent TB. That's a different equation. This is people who've got disease of some kind on their chest x-ray. About 10% a year progress on average. And this has been, they've subsequently in recent studies confirmed this by looking at household contacts in Cape Town. And they found that if in household contacts who had a positive x-ray, but everything else was negative, and they didn't intervene because they weren't sure what to do, about 10% a year developed TB. But also we know without treatment that about 12% per year of patients will actually revert to being culture negative on their own, which I think is interesting. So I'd like to just leave that as a frame for what I'm going to discuss, but I would like to discuss the advancements in terms of the trials that have been performed in rifampicin sensitive, rifampicin resistant, and a few other areas. So what trials have we had in the last few years for rifampicin sensitive TB? And really, I'm just talking about what's essentially on the right-hand side of that diagram that I showed you. So you can see these are in, most of what I'm going to show you is in high-level journals, New England Journal of Medicine, very recent, last year. This is known as Study 31. If you can, if that's blocking your screen as well, but if I move that the way, I can't move that the way. Anyway, this is called Study 31. I don't know why it's called that, other than that's what they called it. And it's a 4-month regimen for people essentially on the right-hand side of the diagram using rifapentine and moxifloxacin. And this is their consort diagram. So they had, it's a big study, 2,500 patients were randomized, and almost equally into the control regimen, which is what we're used to, the 6-month regimen. And then there was a rifapentine regimen where essentially rifapentine replaced rifampicin. And then there was another one where rifapentine and moxifloxacin replaced rifampicin, but they were treated for 4 months. So the key is that this group was treated for 6 months. These two groups were treated for 4 months. My slides won't move now. And this is what they found. So this is the control regimen. You can see that this is the big diagram. You can see that they're looking for unfavorable outcomes. This is basically death, not lost to follow-up, and having disease at the end of treatment. Essentially, these are the sort of big groups of things that you don't want to happen. And you can see that the lines are relatively close, and they all look pretty similar. But when you sort of hone in a little bit, this is just a magnification. You can see that the rifapentine, where they just did 4 months of rifapentine, didn't do so well. It had more bad things happening. But the control and the rifapentine moxifloxacin group were basically the same. And so the regimen is 2 months of isoniazid, rifapentine, moxifloxacin, and pyrazinamide, followed by and then you drop the pyrazinamide and you just give those 3 drugs for 2 months, and you finish in 4 months. So people are quite excited about this, about the possibility of treating, quite severe TB with 4 months of treatment. A couple of caveats are that only 8% of the patients had HIV, and they mostly had CD4 counts over 300. So I think it would be a stretch, and I think we're all thinking this would be a stretch to apply this to patients with HIV before it had been studied in them, but it certainly looks like a promising way forward. This is even more exciting if in some ways, also published today actually in full. If you look in the New England Journal of Medicine, which I received in my inbox this morning, it was actually published today, but you could see it online before that, and it was published at a conference previous to that. And this is a very interesting group of researchers. This Professor Nick Payton, if any of you follow the HIV literature and know the Nadia study and the Ernest study, those were his studies. Very impressive guy. And they wanted to look at strategies. So this wasn't it was a treatment shortening, but it wasn't just, oh, you just give 2 months and then stop. It was, and I'll explain exactly what they were, but they weren't just trialing one duration against the other. They were essentially trialing different strategies. And they actually had 5 groups to begin with. But they actually, for sort of trial-related reasons, they dropped 2 of these strategies, even though they weren't looking too terrible. So there's somebody who's not muted. Could the person who's not muted please mute? Thank you. And they actually dropped 2 of these strategies, not because they were performing badly, but because they wanted to have more power for the other studies. And what they ended up with was the two studies that were compared were the standard treatment, as we've talked about, 6 months that we're all used to, and then this strategy where they gave bedaquiline, linezolid, isoniazid, pyrazinamide, and ethambutol, so 5 drugs for 8 weeks. And then at 8 weeks, they made a decision. They either stopped if there were no symptoms and the sputum smear had become negative, they stopped. Otherwise, they extended for another 4 weeks. And if they still weren't doing well, after 12 weeks, then they changed them to a standard 24-week regimen like this. It's actually hard to find out, but most people stopped at 8 weeks. At I think about 15% carried on. So most people would treat at 8 weeks, but this was a strategy based on how people are doing after 8 weeks, rather than just saying 8 weeks of treatment. But that's just remember, that's just 2 months of treatment. And this showed this was non-inferior. Basically, they were the same. They don't have a nice graph like the last one, but they do have all these this forest plot of all the subgroups. And you can, the way that, if you don't familiar with forest plots, this line is the line of where each strategy is equal, and if anything falls to this side of the line, it means the standard of treatment was better. Anything towards this line, then the bedaquiline, linezolid, etc. regimen was better. And you can see they're basically all the same. You know, essentially everything, regardless who you were, male, female, etc., etc. Thin, not thin, cavities, not cavities, didn't make any difference. This worked well. On caveat is there were 0 patients with HIV in the whole study, so we don't know, and nobody is at the moment going to be suggesting this regimen. I don't think, until it's been studied further. But it is certainly very interesting to see how very effective drugs like bedaquiline and linezolid can potentially shorten TB treatment. I mentioned briefly the SHINE trial. This also very exciting in pediatrics, not really my field, but very, very interesting. Published almost a year ago, actually, almost to the day. Shorter treatment of non-severe tuberculosis in African and Indian children. So if you remember the graph that the diagram which I began with, moving from left to right, these were children who weren't on the far right-hand side. They were just one step in from the left, So you probably know, anyone who looks after kids like this know that tuberculosis is often smear negative, because you can't get smears from them and it's hard to diagnose. So these were smear negative children. They were on average about 3 years old, and they were largely diagnosed based on their symptoms and their chest X-ray, but they had to have just one lobe affected, no cavities, no miliary TB, no complex pleuroeffusions, no area obstruction, or they could have just had simple peripheral lymph node TB. So essentially the most severe cases were excluded in these sort of 3-year-olds, and quite a big study. 1,200 were randomized into two groups. Essentially, the standard treatment that we're used to for children, and then essentially you just stop the treatment. You use the same regimen, but you just stopped at 4 months. You didn't give the last 2 months of treatment. And you can see similar thing here: 4 months treatment better, 6 months treatment better. There's basically no difference in any populations, and this was a non-inferiority margin. But the bottom line is that this seems perfectly adequate, and in fact was adopted almost immediately by the WHO as a standard of care treatment for children who meet these criteria. Okay, so that's rifampicin susceptible TB. Now let's have a look at rifampicin resistant TB. And again, lots of very interesting studies that have come about in the last few years, often carried out in South Africa, in fact. So many of you may know the Xenix study, which was published again last year in the New England Journal of Medicine. A bedaquiline, pretomanid, linezolid regimen for drug-resistant TB. So BPAL, bedaquiline, pretomanid PA, and then linezolid L. So just 3 drugs for 6 months, typically. Now, we'd already learned from the previous study that this regimen appeared to be effective when it was given in the the name escapes me, the name of the first study. We knew that this regimen was effective in people with XDR TB, so highly resistant TB. But what they wanted to find out was, they had problems with linezolid toxicity. So linezolid causes anemia and neurological problems, peripheral neuropathy, optic neuropathy, when it's given for long periods of time at high doses. And so while that was, they kind of managed that in these people with XDR TB who were going to die, they sort of changed the doses. They wanted to know what the optimum dose would be of linezolid, essentially. And so they gave, you can see they gave bedaquiline at its normal dose plus pretomanid, and then they changed the dose and duration of linezolid. And so there was, these groups are much smaller because that's typically what you find. They gave linezolid 1,200 once a day for 6 months, 1,200 once a day for 9 weeks, 600 once a day for 6 months, or 600 once a day for 9 weeks. And you can see in terms of unfavorable outcomes, firstly, the results are excellent. The vast majority of patients do very well, and essentially they're the same. These numbers are quite small, 45 in each group, and so everything kind of overlaps in terms of confidence intervals, and whichever one of these regimens you use is probably fine, which is very reassuring. What they want, the most interesting, or really one of the main reasons they did this study, was to look at what happened with the linezolid, and this is time to dose modification, essentially, when they had to change the dose or stop the linezolid because of toxicity. And you can see that in the high dose groups, then they had, the toxicity was quite severe, but in the this group, which performed the best, a 600 for 26 weeks, which performed slightly better when you look at these graphs. Performs the ones where you use 6 months of linezolid perform slightly better, but 600 didn't really cause huge amounts of toxicity. So this regimen, known as BPAL, with linezolid 600 for 6 months, is and these patients were MDR, not XDR patients, has been approved by the WHO. And I don't write the South African TB guidelines, but my understanding is that soon, when they are published, that will be the standard of care for patients with resistant TB in South Africa. Don't hold me to that, but that's what I understand. And so all this long regimen, short regimen, clofazimine, all these things that are currently in the regimen will drop away, I believe, and then we'll simply have all patients. So that would include fluoroquinolone resistance, so eventually pre-XDR patients would all be on one regimen, which would make life very simple. A very similar study called TB Practical, which was again published last year, was a very similar type of study, a 24-week all-oral regimen for rifampicin-resistant TB. So pretty similar to what we just discussed, and it basically had very similar findings. So those are slightly bigger groups, 150 in each group, and they had a standard of care for RIF-resistant TB, which was it changed over time because we've been through these various regimens with injectables, without injectables, long duration, shorter duration, etc. And then they had these three regimens which they tried. On the right-hand side is BPAL, which is what we just discussed. BPAL plus clofazimine, or BPAL plus moxifloxacin. So these were the three regimens, and they actually found that the BPAL moxifloxacin, BPAL-M, performed the best. And in terms of unfavorable outcomes, the standard of care had 48% unfavorable outcomes, and the BPAL-M group had 11% unfavorable outcomes. And so BPAL-M was both non-inferior and superior to the standard of care regimen. So the debate, what you'll probably be asking me is, why is it BPAL or BPAL-M that we're going to use? And the answer is I don't know for sure. It seems that BPAL does work fine, particularly if someone is resistant to moxifloxacin. There doesn't seem much point giving it. I don't know exactly what the regimens are going to say, but BPAL or BPAL-M seem to be highly effective, relatively low toxicity regimens for patients with rifampicin-resistant TB, which is great news if you've lived through the era of 18-month injectable regimens and things that were just so terrible. Okay, so I'm going to move on to TB prevention. So that's essentially where we are with sensitive and resistant TB. What about TB prevention? Well, in an HIV negative world, not much has changed. So that's why I'm not really going to go into that. We've known for decades that giving something like 6 months of isoniazid to HIV negative people was effective in preventing TB, but only if they had a positive immune reaction. So either they were skin test TST positive or IGRA positive. But in patients who were IGRA or skin test negative, it didn't have any effect. And that's been shown over and over and over in HIV negative people over the decades. And that essentially remains the same. There have been some updates in the TB, in the excuse me, the HIV world, some of which I'll just tell you orally without the slides. So there was a study about 10 years ago called the Tuberculosis study, but it was a lot of patients were not on ARVs, which is not really what we see these days. We're getting people on ARVs very quickly, and it actually showed that very long duration of isoniazid, 3 years of isoniazid in patients with HIV whose TST skin test was negative, was harmful. But if they were TST positive, it was beneficial. But when I say harmful, these patients died compared to those who took placebo. So that was a very worrying finding about 10 years ago. It seems to have been sort of swept under the carpet, partly because those patients were largely not on ARVs, and now everyone's on ARVs, so people have kind of forgotten about it. Then there was a study by Lely Rangaka and Gary Martins, with the first real study in patients taking ARVs with IPT. They used 12 months of isoniazid, and they showed, regardless of TST result, it's the first study where skin test results TST didn't make any difference in these patients who were initiating ARVs, and IPT isoniazid for 12 months was effective, but it was for the first time ever independent of skin tests, and that's one of the reasons why skin tests and IGRAs are no longer in guidelines, because they in the HIV world, because they don't predict response, at least in that study. So I just wanted to talk about what I didn't talk about in that very first picture, was the risk of going from the far left-hand side to the far right-hand side of the graph. And there's a couple of people have been looking at this for years. What makes you go from latent TB to active TB, regardless of what was in the middle that we discussed. And this just gives you some idea, some sort of relative risks. Essentially, HIV/AIDS is 10 to 100 times more likely if you're the close contact of somebody with TB, 15 times more likely. Other forms of immunosuppression, increase your risk. Even silicosis increases your risk independent of being in a mine. These are the highest risk factors. And then other things, being a health worker, having diabetes has been shown. There's lots of papers showing that diabetes predisposes you to active TB, smoking, and even being thin, interestingly, predisposes you to getting TB. It's not the TB that makes you thin, it's the thin that makes you have TB. So what's new? This is Temprano. This was published a couple of years ago, actually, in the New England Journal of Medicine again. This was one of those studies where they wanted to know whether we should be starting ARVs on all patients or waiting until their CD4 dropped. So, you know, a few years ago now. But they also had a sort of 2x2 factorial design where some patients got isoniazid and some didn't. And so they had 4 groups. Deferred ART, early ART, and then IPT or not. And you can see that IPT was quite effective. And it also gives you an idea of how many people in this group were getting TB. So you know, looking over 6 years, you're looking at 5% of people. It's not a vast number. This was done in West Africa, rather than South Africa, where TB incidence is a bit lower. But the difference here is statistically significant, suggesting once again, well, like Gary and Lele's paper, that the IPT is effective in patients who are on ART in general. This was published. This was actually published a long time ago, but I'm going to mention it because it keeps being brought up, and there have been studies since. This is Prevent TB. So this was an attempt to use a 3-month rifapentine isoniazid regimen instead of 6 months of isoniazid. And the 3-month when we say 3-month regimen, it's once a week. So it's rifapentine and isoniazid taken together once a week, and then nothing for 6 days, then take it again, versus taking isoniazid every day. This was done in South America, and this is the bottom line. There's lots of lines on this, but just to show you, this is the line of no effects. This is if you took the rifapentine compared to no effect. So very, very slightly favors the combination therapy. These are the confidence intervals either side, but not significantly so. So essentially, they're the same. Bottom line is that in this group, 3 months of 3-HP, as we know, as it's known, and 6H were the same. They were non-inferior, no important difference. But what you hear a lot of people telling you is that, oh yes, but the 3-HP group had less side effects, so it's a good idea. Well, not a lot of people, I don't think, have actually read the paper properly. If you read the paper, you can see that this is these are the adverse events in the study. This is the isoniazid combination group, large numbers of people, 4,000. Actually, permanent drug discontinuation because of an adverse event was 3.7 in the isoniazid and 4.9 in the combination therapy, which was statistically significant. So actually, people are more likely to stop the drug if they're on the 3-HP than they are on isoniazid. People who are proponents of 3-HP like to say yes, but there were slightly less ALT rises and things, which is true. But actually, it had more adverse events. I'm not trying to put you off 3-HP. I don't think 3-HP is a viable option largely because of cost. People will say, oh yes, but the people on 3-HP were more likely to finish their treatment. But even if that was important, then it would have performed better. You know, this is a study of people who took 3-HP and completed it versus people who took 6H and didn't complete it, and yet there's still no difference. So you could argue that actually taking 6H and completing it is might be even better. But completing the fact that you're more likely to complete the course to me is largely irrelevant. What we know is that the strategy is the same, but we also know that 3-HP is very expensive. And again, people have tried to fudge that by saying that by doing costing models where for 6H you have to go to the clinic every month, So you have to make 6 visits to the clinic, which is clearly nonsense. There's no reason why someone on isoniazid needs 6H needs to go to the clinic every month to pick up their INH. 2 visits to the clinic is plenty. And so when you use more realistic assumptions, then the cost of 3HP is a lot more than 6H. And if cost wasn't a factor, then it, whatever you like, it doesn't really matter. Okay, so this was published today. Literally, I've got a copy. They're called guidelines for treatment of tuberculosis infection. I'm trying to move this out of the way, which is really confusing. National guidelines on the treatment of tuberculosis infection. What they actually are the national guidelines on TB preventative therapy. So treating the people on the far left-hand side of the diagram we started with, but they're using the word infection rather than disease. But I think that's really confusing. They should really be known as the TPT guidelines or something similar. And they were launched anyway. They've been in their wings for a long time, and they were put on the website, the Knowledge Hub website, literally today. Although I was involved in them to some extent, and I've seen them up to now. So what do they say? Okay, so this is the general algorithm. Can I make this smaller? No. The general algorithm of who should be treated, offer preventative therapy, or so essentially they're saying you either offered preventative therapy or you start TB treatment. The people to evaluate are first evaluation of all people with HIV. Okay, so the first time you see someone with HIV, you evaluate them. Fine. This is an important addition. All household contacts, all household and other close TB contacts. So then there's a definition of household contacts, but essentially if you live in the same house as somebody with TB, then you should be considered. And then first evaluation of other high-risk groups, which are listed somewhere. And essentially it's an evaluation to see if you're on the far right-hand side or the far left-hand side of the diagram. And I've explained to you that is a little simplistic, because there will be people who are in that middle zone. And that's really why I presented that to you. But what the assumption is, if people have no symptoms, normal examination, if they've got sputum, you can send it for gene expert, and that's negative. If they have a chest X-ray, it's normal, but a lack of a chest X-ray shouldn't be a barrier. And then offer counseling for HIV status. And if they have none of those, they have no TB disease, they get preventative therapy. And if they found to have TB, they get standard therapy. And I've explained to you why that is not essentially going to be correct. But I'm not suggesting these are wrong, these guidelines. I'm just suggesting that in a few years' time, these guidelines will be more nuanced and will include groups in the middle as well. And then I'm just going to, okay, I'm trying to move this silly thing out of the way. I'll just put it there to show you the regimen. So essentially it's a regimen agnostic, and I've given my arguments for why isoniazid is probably preferable, and it's largely to do with cost. But you can see there's 3HP, there's 12H, and then in children, there's things like 3HR and 6H. This is an important asterisk here. Okay, this is HIV positive people, 3HP for adults and adolescents. Initiating dolutegravir containing ART, 12H is preferred. So actually saying, and again, I don't think this is necessarily correct. This is because there's this suggestion of a drug interaction between rifapentine and dolutegravir, which actually doesn't seem to be clinically significant. Actually, suggestion is that you should use 12H in patients initiating dolutegravir, which is all patients initiating ART. That's what the guideline says. And you can look these whole guidelines up if you're interested in these things, and find out everything about HIV positive, negative children, HIV negative adults. Again, lots of possible regimens to use for each group. Okay, so that's really treatment. Now I'm going to just touch on diagnosis. How much time have we got? Okay, and I'm going to keep this fairly brief and just stick to one new diagnostic. So you'll be aware already of GeneXpert and Expert Ultra, and also these cartridges for drug resistance. I'm not going to go into those. You'll be aware of Urine Lam, which has been around for a decade. But one of the most exciting and interesting new diagnostics, I think, is something called face mask sampling. This paper is from 2020. The original paper was a few years before that. It's a group from the UK. And essentially what they do is they give you a mask, like a surgical mask, and inside the mask, they tape some, this is how they initially did it, they just taped in some strips that would absorb your breath going in and out of your mask. So you didn't need to have sputum. You didn't need to. There was no because everyone might be wearing masks in the clinic, particularly these days, or should be. There was no stigma attached, and essentially you just put this mask on and wear it for about 30 minutes, and then they take the strips out of the mask and then put it essentially through a GeneXpert machine. And they did this study in Pretoria, and where they went looking for patients with symptoms, but it was active case finding. They went out and asked people if they had symptoms, and they found these patients with symptoms. And interestingly, and they did face mask sampling and they did sputum sampling. And the interesting thing, although these are small numbers, I do think it's fascinating. They found these 6 participants who were positive on their face mask, but their sputum was negative. And the whole numbers weren't small. So this was a reasonable proportion of patients. So just as that again, when they coughed up sputum, it was negative for GeneXpert. But using this method with these this mask and these strips, they were positive. And they followed up. One of them they lost, but 5 of them they followed up, and they did quite a lot of work on them. These are the 5 patients, and so 4 of them they ultimately put them on TB treatment. Why? Because when they followed them at 6 weeks, they'd become sputum positive. Okay, so initially their sputum is negative, their face mask positive. Then 6 weeks later, their sputum has all become positive, and the face mask stays positive. And they actually gave them PET scans. So chest X-rays still look normal, so you wouldn't pick them up on chest X-ray. A couple of them, they did do a bronchoscopy, but they did these CT PET scans, which were all positive at 6 weeks. So it's essentially, and I'll show you some pictures, and they started them on TB treatment. One of them they didn't because they found another diagnosis, and they never became sputum positive. So that's a slightly odd one. But they followed at 20 weeks, they all had become negative of their treatment. And so this is the kind of thing they found. So this is the kind of patient that, like I say, initially is face mask positive. They didn't do a PET CT on day 1. Admittedly, they did it on day 6, on 6 weeks, which is when the sputum had actually become positive by this stage. But their PET CT scan starts to light up, and then at 20 weeks they repeat the PET scan and it's all gone away. So the suggestion really is that these face masks may be able to, firstly, they're quite convenient, but they may be able to pick people up before they start becoming sputum positive, before they start, maybe their PET scan was already positive, we don't know. But importantly, that would mean that you could be picking them up before they were causing symptoms, spreading TB, so that they're before they were a source of infection for other people. So I think that's very interesting. Lots of people are interested in these masks now. Lots of people planning studies, initially the masks were just sort of made in their garage, but now they're being made a little bit more professionally. I think this is an important area to watch. So I'm just gonna finish with a few. I'm just looking at the time. Okay, going up to 7. A couple of points. So, I mean, some of these things are down here. These face mask diagnostics, are these face mask diagnostics picking up people like somewhere here before things are positive? I think that's really interesting. And the other thing that's interesting is something I'm involved with. I just thought you might be interested in is how should we, if we find these people here, how should we be treating them? At the moment, we're giving them this 6 months of treatment, or we're not giving them any treatment. That's almost certainly wrong. And it's almost certain that these patients require some sort of intermediate treatment. Remember, they've got 10% of these people in 1 year. If you find 10 of these, one of them will be here in a year, coughing up and transmitting TB. So compared to this group where, you have to treat hundreds of people, well, not hundreds, but lots of people here to prevent them going here and being transmitters, it's much more effective to pick people up in this point and treat them. But what do we treat them with? So how would we pick them up? They'd be asymptomatic probably. They may have a few symptoms, but largely they'd be asymptomatic. So you'd have to go out into the community and find them. And the only real test that's of use is actually chest X-ray. So the group I'm interested in are actually these ones here who are negative on all their tests. The culture might be positive or not, but essentially their expert is negative, but their X-ray is abnormal. And so this brings me to machine learning. I didn't put slides on machine learning, but you're probably aware of a number of at least 3 or 4 companies that have got machine learning algorithms for chest X-rays. They're basically aimed in this market. They're not really aimed at diagnosing TB in this group, and certainly not in like hospitalized, very sick patients where they work very poorly. But this is the kind of group which they're very good at picking up. And so with quite a high degree of accuracy, if you go and do enough chest X-rays, you'll pick up people in this kind of group. And then the study that I'm hoping to be involved in is randomizing people to different regimens, which it kind of says here. Shorter regimens, 2 or 4 months, maybe 2 or 3 drugs, much less toxic, much easier to take, but actually very effective in preventing people from progressing to symptoms which they don't want, a lung destruction they don't want, and transmission, which nobody wants. Okay, so I think I'll leave it at that, if that's okay. And yeah, hand it over for any questions. It's gone very dark in my room.
Thanks very much, Dr. Tom Boyles. I see you've got load shedding also that side.
I haven't actually. I just didn't realize because I didn't see my face. I didn't turn my light on.
Oh, sorry.
I actually don't, but because I couldn't see my face, I didn't realize it had gone so dark. I was concentrating.
I had load shedding just before we started, and last week I was in the dark also. And one of my colleagues is on load shedding, was asking him to help, but he's sitting in the dark now. Quite interesting, and I'm so glad that you also mentioned that there's a new treatment guidelines. So you're always on your feet looking for new information that is published just today. Are you able to share the link with the colleagues who are logged in here?
It's on the Knowledge Hub. The
Knowledge Hub.
Yeah, I can look for it. Somebody sent me the link.
Okay.
I can certainly look for it, but yeah.
Thanks for that.
But it's available on the you know what I mean, the Knowledge Hub.
I know the Knowledge Hub. Yeah. Someone has put. Yeah. Is this?
Someone posted it already.
That's name, and thank you for sharing that information. If everybody can just copy and paste that link, and yeah, thanks very much. You also mentioned something quite interesting, because in most cases which I think is still the case, that people who are diagnosed with TB tend to lose weight. But you said that there are those who are thin, who are actually high risk factors for TB. That's what you mentioned.
Yeah, it's true. So it is true that if you are underweight, you're more likely to get TB because you're underweight. Now, being overweight actually is protective unless you've got diabetes. So being overweight is protective against getting TB. But if you're diabetic, overweight and diabetic, then you're not. But actually, I don't know the reason. I don't know. Somebody probably knows the reason. But yes,
some few years back, many years back, I contracted TB, and I wasn't losing weight.
Okay.
And I saw physicians and one pulmonologist, and they couldn't diagnose it until someone said, "Hey, let's just check for TB." And that's the only time that we did a gene expert that time, about many years ago. Thank you very much. And yeah, the information is quite recent as you sharing that which you have shared with us today, and the different treatment regimes that you're saying. And I think I like the idea, as I mentioned, machine learning, that we spent some time, the whole month last year. I didn't know at that time that there was also something going on with machine learning, with TB treatment at the time.
No, very much so. It's one of the most advanced areas of chest X-rays. Is this TB screening using chest X-rays is one of the more advanced areas of machine learning certainly in X-rays, and there's multiple commercial systems out there.
Okay, thanks for that. I'm trying to look for someone says very interesting, complicating, very informative. Colleagues, please, if you've got any questions, please do post them on the chat line, or just raise your hand and ask Dr. Tom Boyles a question if you have any question. You should be having questions. I mean, TB, I mean, we live in South Africa, and I think TB, it's, if I were to use this expression, the bread and butter of our livelihood in terms of patients that you see. And definitely, there's still, yes, you've indicated there's still a link between TB infection and HIV infection, and that's the space that you're working in.
Very much so, yeah. I think it's I think not just from a research point of view, but from a practical point of view, understanding this spectrum of TB disease, and although it's our thinking is only in its infancy really, and it's not as straightforward as I suggest. It's just a straight line. Everyone goes along the same line backwards, and then some go forward and some go back. You know, some will get symptoms early, some will get chest X-ray changes early, some will get a culture early or late. You know, it's not just a straight line. And you know, one of the things we need to do is have good definitions. The phrase incipient TB is used, but it doesn't have no one's decided on the exact definition. It seems to mean your chest X-ray is positive, but your sputum is negative, and you may or may not have symptoms. That's what incipient T is sometimes used for, but it needs to be nailed down so that everyone knows what they're discussing.
Yeah.
Someone's asked me any recommendations on vitamins.
Yeah.
Yes.
Any comments on that one? Yeah.
There's been a lot of studies of taking vitamin D along with treatment, and they're pretty disappointing actually. There have been some suggestions that taking vitamin D along with TB treatment, and the whole story of vitamin D and TB is quite interesting. Western Cape is a good example, because the amount of vitamin D people have fluctuates a lot during the year in that sort of more temperate climate. So in the winter, people tend to go inside, and it's cloudy and rainy, and vitamin D levels go down, and TB goes up, and then the reverse in the summer. But that doesn't, of course, mean there's cause and effect. It could just be that because you're inside your house, you know, with your family, you're more likely to spread TB. But the rates of TB are much higher around the winter time than the summertime in the Western Cape. And if you draw a graph of TB cases and vitamin D, they overlap, but that doesn't mean they're cause and effect. But there's been a lot of discussion about this, about whether you should be giving people vitamin D to prevent TB. And I think there are ongoing studies to see if that works. There have been lots of studies of adding vitamin D to treatment, people who've got TB, and they've been largely disappointing. It's not an expensive or toxic treatment, but it certainly hasn't got a major effect.
Yeah. Okay. Colleagues, please do ask any questions. I'm sure some of you are in practice and you see lots of patients. There's Dr. Lambert also, lots of patients with chronic, sorry, today I skipped it. There's another one came. There are lots of patients with chronic cough, negative for TB, a typical chest X-ray, getting diagnosed as sarcoid. Are they not for TB treatment empirically?
So is that a question on the group, or have you just asked me?
Yes, it's a question on the chat group, yeah. There's one
I've got one from Dr. Desai.
Oh, so no. It didn't come to, it came straight to me. Sorry.
Can I just do the one that we can all see, and then you can ask that one? So
okay.
Dr. Desai says, TB prophylaxis. You said we should do a skin test, and if positive, we should give INH. Don't we treat the positive test? So no. So if someone has no symptoms, so they're on the far left-hand side of the graph, we do a skin test or an interferon test to see if they're immune sensitized. And if they're positive, that all that means is that they're essentially on the left-hand side, and that they are more likely to benefit from isoniazid monotherapy if their skin test positive. It's a different matter if they've got symptoms. If they've got symptoms, then they need to be investigated to see where on the spectrum they lie. But typically, like I say, we only have one other form of treatment at the moment, which is 6 months of therapy. But not you would never treat somebody with 6 months of combination therapy purely on a skin test or a quantiferon. They might have that positive and have symptoms, but no, it's to determine immune sensitization. So no, we don't treat the positive test. I know that in pediatrics that test is used because they got so difficult to diagnose TB in children that they do use skin tests. That's not my area, and I know it's a difficult area. But again, you're not treating the test. You're testing the patient.
The next one that you can read there, how helpful is TB?
How helpful is TB quantiferon assays in diagnosis of TB? Well, I think I just answered that largely. Again, amazing how London buses come along, but I was actually discussing this on Twitter with some people today. And I actually looked up a paper which looked at the diagnostic performance of quantiferon for smear negative TB, which is kind of where you might want to use it, or in the old days, and it really performs very poorly. A positive test nudges your thinking slightly in the favor of it being TB, and a negative test nudges it slightly against it being TB, but really they perform very poorly as diagnostics. So I wouldn't recommend largely using quantiferon. There are much better ways of diagnosing TB. Chest X-ray, particularly in the HIV negative group, but also in HIV positives, and certainly in people who've not had TB before, chest X-ray is the best test, actually, for the most sensitive test. If the chest X-ray is negative, they haven't got TB, basically. If the chest X-ray is positive, then you've got something to go for. You can get sputum, hopefully, even if it has to be induced. So I wouldn't. So essentially, it doesn't have a role in diagnosis, particularly in advanced HIV, where it goes negative again. So someone who was positive, their immune system becomes so weak with the low CD4 count that their quantiferon becomes negative again. They might be completely ravaged with TB, but their quantiferon is negative because their immune system is so weak, and so that's why we don't use it.
Okay. The one that you didn't say that came straight to me, Dr. Lambert, is lots of patients with chronic cough, negative for TB, a typical chest X-ray, and they're getting diagnosed as sarcoid. Are they not for TB treatment empirically? Good
question. That's a good question. The differentiating TB from sarcoid is not straightforward at all. I mean, there are tests like serum ACE, which you'll be aware of. So it's certainly possible to have positive chest X-ray and negative tests and have a form of TB. And if I could, and perhaps if can I still share my screen or not? Yeah, I can. If I can just go back to, oh no, I can't share my screen. But when I showed you that first diagram there, I didn't say that sometimes the TB tests are all negative, but the chest X-ray is positive. That probably means they don't have severe TB, but they might. Diagnosing sarcoid is not straightforward, but a serum ACE can help differentiate the two. And really, that's the kind of patient that should probably go to a respiratory specialist if that is your true differential diagnosis, because the treatment for sarcoid is largely steroids or immunosuppression, and the treatment for TB is the opposite. And so it is something that you really do want to find the difference. And it might well be that patient, particularly in a private setting where it's available, would benefit from perhaps a high-res CT scan and a bronchoscopy and a biopsy. And to make that differentiation. It's not something that I deal with. I don't deal with sarcoid very much, and I haven't made the diagnosis often, but it's certainly not a straightforward one.
Okay. Before we go to this question, I saw a hand, or if you still want to ask a question, you can raise your hand and we'll come back to you. Let's follow. Oh, okay, go ahead.
In a drug-induced liver injury with a rifampicin-resistant patient, how would you approach that one?
Okay, a drug-induced liver injury in a rifampicin-resistant patient. So,
yeah, how would you reintroduce the treatment after some slight improvement of the liver function?
Yeah, well, it depends a little bit what they were on, because we've discussed there are different regimens. So what we'll probably be moving over to BPAL for most patients, but I assume you're talking about a different regimen. What sort of regimen are you thinking of that the patient developed the liver injury on?
The regimen that we're using.
The current regimen, so sort of bedaquiline, levofloxacin, clofazimine, linezolid.
No. Just ethambutol, isoniazid, and PZA, thionamide.
Sorry, I missed that. Say that again. What are they taking?
Ethambutol, thionamide, PZA, and INH would be the ones that we're using together with the rifampicin. But then the patient came up with resistance for rifampicin. How would you then reintroduce the antibacterials going forward when the liver has improved?
So then they need I see what you mean. So you treat them with rifampicin, you treat them with the rifampicin, but then you realize they get liver injury, and then you realize they're resistant. But you're actually in a better position then, because you can give them, the basic theory behind drug toxicity, be it liver injury or not, is not to reintroduce drugs. Now, we're so used to the fact that in TB we don't have a choice, because we have, until recently, have had so few drugs. This concept that we re-challenge people with toxicity with the same drugs they've been on is not the norm. The norm is to avoid those drugs completely, and use different drugs generally. In TB, we don't do that. But in your situation, it's actually kind of fine, because you want to give the patient completely different drugs. You want to give them, bedaquiline, levofloxacin, clofazimine, linezolid, and you can certainly manage without the pyrazinamide and the ethambutol, or the ethambutol doesn't typically cause liver injury. So you can actually use a standard drug-resistant regimen, and not re-challenge the drugs that probably did it, which are the PZA, the isoniazid, or the rifampicin. If I've got your question correct.
Yeah, that's right. Yeah, thank you. Okay.
So those are kind of the standard treatment regimen that is being used. I mean, this has been for many years, the 4 drugs that you mentioned. But you moved on to different drug regimen completely.
Yes, and that it's more of a. I mean, the question more on my lips in a way is what if that patient isn't rifampicin resistant? They get a drug injury on the typical 4 drugs. Should we, because we're so used to re-challenging those drugs, but like I said, that's because we've been forced to, because we didn't have anything else. But should we actually say, okay, no, our second line drugs, or we're calling them second line, our drugs for resistant are so good now. Should we just abandon Rifa-4 and go to other drugs? I think there's a good argument for doing that. I think we know that the bedaquiline, pretomanid, linezolid regimens are so good. You saw those results, 95% good outcomes, that there's a good argument for doing that. It's not in any guideline. Maybe we should have a trial. Maybe we should just do a trial where all the patients with drug-induced liver injury are randomized to either re-challenge, like we've always done, or just switch to completely new drugs and see if it makes a difference. I think that would be quite an interesting study to do.
Recently, there was a shortage, or it's a matter of moving from one company to another, and Rifa-4 was not easily available. And not for certain in the private sector, you wouldn't get Rifa-4, and in the public sector, I'm sure they were changing. So that situation for you, would you say that was a welcome situation, because then it forces you to move away from this?
I'd rather there was evidence. I'd rather there was evidence. I'd rather we, at the moment, we're sort of sticking to dogma, and unless the liver injury was incredibly severe, we're sticking to dogma and re-challenging. And to be fair, re-challenging usually goes quite well. People don't die from re-challenging drugs. The worst thing that happens is that their liver deteriorates, and then we stop the whatever we'd re-challenged, and then we definitely are going to use some new drugs. So it's not like re-challenging rifampicin is dangerous, largely, but it may not be that efficient. And so I just wonder, particularly with new drugs, we should just abandon re-challenge. But that's not in any guideline. I'm not suggesting everyone does that, but certainly a question.
Yeah, I hear you. Back to HIV. In HIV patients with low CD4 counts, and the patient improves on TB treatment, but all investigations are negative, would you continue treatment as you are waiting for TB cultures to come back in 6 weeks?
Generally, yes. Of course, every patient is different, but the picture that you present there, absolutely. Patients who, what you're suggesting is the patient was sick because you said they've improved, they've got low CD4 out, they're sick. And, obviously every patient is different, and perhaps you're treating them for other things, but if they're improving and they're tolerating the drugs, then I would definitely continue. And as I said, on that picture, you can have negative culture and still have TB. We all recognize that is possible, for whatever reason. So even if the culture is negative, you don't necessarily say this wasn't TB, for sure.
The patient was improving.
Yeah, if the patient has got typical symptoms, makes a good response to treatment, and they're tolerating the treatment, and so it's really not it's not expensive treatment. It's not, they're tolerating it. It probably won't get toxicity. Then it's probably better to continue. It's a bit different matter if the patient doesn't get better, or they've got a drug-induced liver injury. Then you'd be questioning whether the diagnosis was correct. But in a patient who's doing well, because we know even culture isn't perfect, the tendency, the default would be to carry on. You can obviously make your own decision based on the patient in front of you, but the default would be to carry on.
Yeah. I think we're close to the end. There are no further questions, and I just want to thank you very much for availing yourself to come and share your thoughts,
pleasure,
experience, and what you're doing at Ellen Joseph Tembalete Clinic. I think it's still called.
Yep, Tembalete Clinic. Yeah, good
work that R2K is doing there. And thank you very much for being here and sharing up-to-date information. It's amazing that we were able to get hot off the press TB treatment guidelines today.
Yes.
And you shared quite a lot of information from the research papers that you've been reading from NEJM, quite up-to-date information. And I think this is what the platform is for, to get new knowledge and new experiences, and also see how patients are doing. People like you presenting their clinical experiences from where they are. And we're happy to have you present to us. And
my pleasure. Thank you for listening and not falling asleep. I appreciate it.
No way for falling asleep. And thanks to Ian for just pass my regards to him. He's still there, Ian Zhang at R2K.
Yes.
And so I just want to thank the colleagues who are here, who have joined us. I think every week we get quite great numbers as we listen to different speakers sharing the information. We just want to thank you, colleagues, for tuning in every week, and also to thank our team for marketing. Kamo is the one who's doing the background checks, and Toko does the source checking, getting information from speakers, and we are here together. And next week, we're continuing, we went to a different angle completely, discussing social media. So please come back, colleagues, and we'll be chatting about some stuff that you're reading about, some interesting doctors that we have in our age. So we'll be talking about such things next week. Thank you very much and have a good evening. Thanks a lot, Dr. Boyles.
Thank you. Bye-bye.
Bye-bye.